Are we good to go, Sharon?
Good to go?
Okay. Thanks, everyone. It's Sandy here, and it's really good to host this last event of this year, the troubled year of 2020. And this time we really wanted to try and involve everyone that has been participating from different countries. And obviously the theme of this aspect of gecko is endoscopy. So I think it's very fitting that we find out what's happening in some of the other countries in Africa today. That's really our primary goal, is to help individuals with their problems, both logistic and obviously clinical. What I would like you all to do is to actually take your videos, put your videos on, and I would like a few of you, I'm going to pick on you, to just introduce yourselves and to tell us quite briefly in about 30 seconds what you're up to and why you're listening in to the meeting, because we really want to involve you in this, and we certainly hope that the three talks will provoke some discussion. The last talk is about just to show that we can use this forum for discussing aspects of research, clinical research, and this is a study that's been ongoing in Cape Town at Grooteskieur, run by our former trainee who's now moved into private practice, and he will share some of his results about our steps into H. pylori research. So I would like you to just, those of you who have videos, could you please switch them on? David Chalufa, could you unmute and please put your video on and just say hello to us? That would be good. Are you able to do that? Maybe we need to unmute them. I'm not sure if we can do that.
Hello?
Hello, David. How are you? You're doing it from your car, obviously.
Yes. I'm David Chilufya from Zambia.
Yes.
I am a registrar in internal medicine. I'm studying internal medicine in my third year of study. And I do have interest in gastroenterology. So I benefit greatly from these sessions. Yeah.
That's good. I'm glad you've actually managed to set yourself up in a car. That's more than I would dare to do for one of these meetings. Well done. And nice to have you on board.
Yeah.
Perhaps Amicus.
Thank you very much.
Thank you. Can Amicus Brief, can he also unmute and show us his video if at all possible?
Hi everyone. Hi.
Hello. Where are you from?
Yeah, my name is Dr. Mutura.
All right.
Yeah, or call me Dr. Dominic.
Yes.
I'm actually in my clinic. I've taken a break.
Yes.
Yeah,
That's
so
good.
I also have an interest in gastroenterology. I'm a physician practicing in Kenya.
In Kenya. That's
Yes.
fantastic. We've got one of your professors here who used to train with us. He's going to be talking. So hopefully you might recognize him.
Which professor is this?
Young Rajuba.
Oh, yes, I know him. I know him.
That's good. That's good.
Okay.
And what I think one more before we move to the talks. What about Munar Agel? If you could unmute and just show us your video. if that's possible.
Hello.
Hi.
I don't know. Hi, Dr. Thomas. Hi, everyone.
Hello. Yes. Tell us a little bit
Nia,
about yourself.
yes, I'm a gastroenterology fellow at Chris Hani Bargwanat Hospital with Prof.
Right.
Ali. Yeah.
Right.
So yeah,
Very
we
good.
are enjoying those sessions with all of our team from South Africa. It's very helpful actually.
That's good.
Yeah.
No, indeed. It's good to know that they're well received. So I think that we really do want to get to meet you and at least put a face to the name and a voice to the name, so we can understand who we're trying to move forward in gastroenterology and whether we're doing a good job. So thank you very much for doing that. Yeah. So I think what we will do now is we'll start with the talks on challenges of endoscopy provision. If you'd all now come off your videos if you can, and we'll start with Leo. Leo also trained with us in Cape Town and is now back in Harare, and he's a medical gastroenterologist, and also a thinking gastroenterologist, we could call him. He did his PhD with us when we were here, and he has an interest in colorectal cancer. So Leo is going to start and tell us about challenges in Zimbabwe. Thanks, Leo.
Thank you, Sandy, for the kind introduction, and good afternoon or good evening to everyone. Mine is going to be a very short talk, and my belief is I would suspect that the challenges that we face are replicated everywhere. For those who don't know Zimbabwe, it's sandwiched between South Africa, Botswana, Zambia, and Mozambique. And as of 2012, the population of Zimbabwe was 13 million people. I'd imagine that it should be around the 15 million mark now. And a significant proportion of my compatriots living down south there. And in terms of endoscopy practitioners, these 13 to 15 million people are served by a paltry number of endoscopists. We have 3 gastroenterologists. We have one hepatobiliary surgeon who is a friend of mine who trained with me over the same period. I think you have seen him because he may have given a talk on this platform. We have general surgeons who provide endoscopy. I did a count and came up with 15. And we also have 4 general physicians practicing endoscopy. And mind you, this is right around the country from largely split between Harare and Bulawayo, with a few in Mutare, which is right at the border with Mozambique, as well as Gweru, which is the middle of the country on the map that I have there. When I was thinking of this talk, I think of this book that we read when we were young, Rip Van Winkle, which is the gentleman who slept for many years. And when he woke up, a lot had happened. And the reason I thought of this is going to be captured from the PubMed search that I did of endoscopy, GI, and Zimbabwe. I had to put GI because I was getting up a lot of bronchoscopies. And you can actually see that the first publication of endoscopy in Zimbabwe was in 1975 in the BMJ on causes of upper GI bleeding. And similarly, we had something that I had to put it down there from 1992. And by and large, this was replicated. You can see a publication on experience with colonoscopy in Zimbabwe from 1985, and something on variceal interventions in the country in 1993. And I was actually quite interested to realize that there was someone published on ERCP in Zimbabwe in 1986. I found this quite interesting because we recently resuscitated an ERCP service that we are still trying to make sure that it functions to the fullest experience. So if you go from there, from the 80s and early 90s, there was actually no publication on endoscopy from Zimbabwe right until this article that we published in 2015, which is nearly 15-year hiatus between the two publications, between these publications. And even then, what has been published is rather sparse. I counted not more than 15 articles over the course of history in the country. And really, this poultry research output has accompanied or is actually been a result of regression in clinical practice over the past years. The public sector service, as far as endoscopy is concerned, is very, very limited and concentrated in Harare, with few activities happening in Bulawayo and Gweru. Over this period, some activity has been maintained in the private sector, but even so, it has been limited in scope, and particularly there's been limitations in access. There's really no equitable access to endoscopic services. There have been some recent changes that give a little bit of optimism. And I think this is because we have had several trainees that have come back into the country and tried to give the GI service a little bit of a boost. And we know we have people who are training elsewhere at the moment. And we also have young doctors locally who also interested in GIT and are making headway. I actually saw one of them on this platform, Simba Pumojena, and that gives us hope for the future. I'm going to just give a summary of what I think are the challenges that we have, and possibly opportunities as well. And this would be my last slide, and I will allow my colleagues from elsewhere to go on. And one of the biggest things why you found that in 1985, we had an ERCP service. And when I was in Cape Town, I remember speaking to Peter Cotton, and he kept saying that he did the first ERCP in Rhodesia in 1976. Why we had this, but over the years, there's been significant regression. I think the key thing is that there's been lack of capital investment in equipment, which, although it is improving now, most of the initiatives have been private sector driven as opposed to public sector driven. And the result of this would be in equitable access to endoscopy. There's been a lot of maintenance issues with our endoscopic service. I have experienced this firsthand, where equipment breaks down. You can see it's going to break down because you can actually see the way the equipment handling is. You can't blame anyone because you can see the training has not been up to scratch. And I think these maintenance issues are exacerbated by the unavailability of industry support. The ecosystem is simply not there. There is no after-service support. If your scope breaks down, you have to ship it down to Joburg at least to have it serviced. And you will face lots and lots of red tape in trying to export equipment outside because there are all sorts of forms that have been filled. And I know several colleagues have resorted to putting these things in a bag and just going across. The absence of endoscopy training programs is a critical a critical aspect of this, because if there are no programs, you don't get a lot of public sector work. I mean, when I was training in Cape Town, they would see that units work best if they are trainees, as they is a symbiotic relationship between training and provision of service. And this is also what pushes expansion. There is absolute lack of GI nurses and support staff. And this is one of the things that feeds back to the issues of maintenance of the equipment, and probably contributed to the multiple breakdowns in equipment. There are limitations in the other supporting disciplines. Trying to run a functional endoscopy service without a functional histopathology service is a big issue. I think across the country, I counted less than 7 histopathologists. We do get pathology service in the private sector, but once you talk of the public sector, yes, the pathology service is there, but you may go for months before getting a result, which often impacts on endoscopy service. Similarly, endoscopy and radiology are symbiotic. And as far as I know, we don't have a single radiologist in the public sector, although we have quite a number of radiologists in the private sector. And this just speaks to the dichotomous nature of practice in Zimbabwe, where you have a private sector that's reasonably well resourced, but still has quite a number of procedures and interventions that we could do, and a public sector where there is an absolute lack of resources, which is compounded by the lack of specialists in the various disciplines. And while I do welcome the efforts that have been made just on the last point by the Gastroenterology Society of Sub-Saharan Africa, and which mutated from the Gastro Foundation in terms of advocacy, which is something that I think is key. But I also recognize that for Zimbabwe, we probably actually need GI society that would advocate locally for issues unique to us. And this is something that's not currently in place, but should be in place as we go forward, because we do have a lot of enthusiasm and we have a lot of enthusiastic people. Thank you very much. So Sandy, that's the end of my talk. I put very few slides to allow others to give their...
No, I think you put some of the problems of South Africa in perspective, or Southern Africa in perspective. So hopefully that you've set the scene very well, and I take your point about the advocacy at a local level. Next up is Alan Rajuba. Alan is practicing in Nairobi, and he's going to give his perspective on it from Kenya. Thanks, Alan. Go ahead.
Okay, thanks. So actually, listening to your talk, Leo, about Zimbabwe, I realize we have very many of the same challenges. So I just pretty much go over ours in brief, also just as brief as yours was. Yeah, so obviously we want to discuss that, but it's an extremely endoscopy is extremely diagnostic tool for the assessment of alimentary canal, and it began as far back as the 60s with rigid scopes, and flexible endoscopy became available probably around the late 80s. So 3 decades after the invention of the fiber optic scope. So currently we are 22 registered gastroenterologists. I just lumped all of them together, but about 90% are physicians. Then X number of endoscopists. What I mean by this is that there are a lot of people who are not registered who are practicing endoscopy, and you'll find somebody will actually buy maybe a second-hand endoscopy upper scope and open up a shop somewhere and actually just provide the service at a fee. So we'll talk, maybe I'll just mention a little bit about more of this towards the end, because it's a little bit of a worrying trend. We actually find people who are training from YouTube, buying a scope, and actually providing a service. So obviously this is going to be a problem in the future. It actually already is. We've gotten a few complications and referrals, but anyway, I guess that is beyond our scope. But anyway, that is the X number of endoscopies. So the registered ones are 22. We have about 40 to 50 scopes countrywide. A vast majority of these scopes are actually based here in Nairobi. Then in our public sector, our biggest national hospital is Kenyatta National Hospital, which actually has a full running endoscopy unit, and it also has a dedicated liver clinic. Most major towns will have at least one gastroscope, and basically they'll do at least diagnostic endoscopy. Most scopes available in Nairobi, most scopes, like you mentioned before, are mainly in Nairobi. And major private hospitals have them, like mentioned Nairobi Hospital and Aga Khan Hospital, but also MPSHA. So there are about 4 or 5 private hospitals that will also provide this service. Then, yes, individuals, like we talked about, which is actually a growing trend in the country. So a lot of people just decide to offer endoscopy services, no training whatsoever, and they're actually charging the common wananchi. We don't seem to have any form of control on who is allowed to do endoscopy and who is not allowed to do endoscopy. So this is the Kenyatta National Hospital, which is our biggest referral hospital. And it also is our biggest endoscopy unit in the country with 3 large suites. It doesn't unfortunately offer a 24-hour service yet. It mainly works on public holidays from Monday to Friday up to about midday. So yes, in recent years, it has improved. Over that, I think we had the same problems like they have in Zimbabwe. A scope would break down, it could take even 2-3 years before it is repaired. So actually, even the entire time, I actually did my undergraduate and my MEd, IMEd at KNH, at University of Nairobi in KNH. And the entire time I was there, the endoscopes were not functioning, just the liver clinic. So the repairs, it's a whole lot of bureaucracy on how they get repaired. And actually now that means even getting new scopes is even more difficult. So what are the services available in KNH? It's become quite comprehensive. There's a Dr. Kreitu who has been very fundamental towards pushing this over the last few years. So he's managed to actually get in APC, and even ERCP is now available. They're able to basically do most of the interventional endoscopic procedures, but EUS not yet. The other progress we've had is a collaboration with the Gastro Society of Kenya, with the WGO. And we managed to actually start up the Nairobi Gastroenterology Training Center on the 6th of May, 2016 at the KNH endoscopy unit. So it is a remarkable achievement. It's a first of its kind in East and Central Africa. We do have a few hiccups, which hopefully will get sorted out in the next few years. There is no proper marriage between the university and KNH, even though the university is using the endoscopy unit of KNH. I think in Cape Town, there's a little bit more of an organization between now the hospital, the GSH and UCT, where I think there's some part payment of this faculty from GSH and UCT, and that sort of arrangement so that people work together. So because of this, we've not actually managed to come up with a certifiable curriculum, but we do have ongoing training, and we also provide local training. We have these workshops that we do on a regular basis, well, pre-COVID. We're trying to do them every 2 to 3 months. Actually, Professor Andy has been very fundamental towards helping us towards that. And it is very interesting how all these ex-endoscopies I mentioned about were extremely keen to come. In fact, when you advertise like for 50 people to come in, the slots get fully filled up within days, even if you advertise like 3 months prior to the workshops. So for us, we have agreed to just work as honorary consultants. We get no pay, and we just hold these workshops as often as we can. So for example, we'll have one just on upper GI series, one on colonoscopy and so forth. Now we're even doing ERCP. We've even done 2 EUS workshops. So we've managed to have 2 international gastroenterology workshops, both 2016 and 2018, trying to do it every alternate year. We discovered it's logistically extremely difficult to do it yearly. So how you guys are doing it in South Africa is actually very remarkable. It's extremely, extremely taxing and so many meetings to be held and so forth. But I think the second one was much better than the first one. So I think we're growing. I wish in future we could not have them both on the same month, because I'd really like to be attending the one in South Africa as well as one in Kenya. They're both being held in August, I think about a week apart. And they're very well attended and they continue to improve. So I think this is a step in the right direction. So it took long for us to start, but I think there are some steps that are positive going forward. So most cities will have at least one endoscopy. And unfortunately, what happens, this same dilemma that you have in Zimbabwe, is that once a scope gets broken, that's pretty much it. It will take months and months and even years for a scope to get replaced. Then obviously the lack of safety, especially now the ex-endoscopists who are going to be a very serious problem in the future, who don't sterilize equipment and so forth. And how they train the personnel, it's basically the same way that you teach yourself how to scope on YouTube, the same way you teach your nurse how to take biopsies and so forth. That's a whole other area. Issues with scope repairs and renewals is a standard problem I'm beginning to see. Then ERCP is also available at TENWEC. So out of the public sector, TENWEC is a mission hospital, so technically not really under Kenya's jurisdiction, but they do offer an endoscopy, an ERCP service. So you have in the public sector, you have at KNH and we have at TENWEC. So private sector, this is actually where I work. This is the Aga Khan University Hospital. It's based in Nairobi. We are now 2 full-time adult gastroenterologists. We had a second gastroenterologist join us last month. I was pretty much the only full-timer for about 4 years. Then we have 7 part-time adult gastros. I've mixed the surgeons as well as the physicians. We have 2 full-time pediatric gastros and 1 part-time pediatrician. So I think slowly by slowly we're creating the numbers. Why I'm mentioning this is that I'm hoping in the future we'll be able to, maybe the help of you who have already set up other training centers, that maybe there's a possibility of us actually considering to start one. Of course, the nitty-gritties on how to start one will need pretty much a lot of help. But I think the numbers are developing, and you do have a few people who are interested, like Dr. Mtura, who you talked to earlier. And maybe when more and more people come in and are more interested in actually doing full gastro training and certification, you might actually start thinking about a training program so that you don't have to always send everybody out. So we offer basic endoscopy and colonoscopy, and we offer pretty much every interventional service except EUS. The EUS have been asking for it for the last 5 years, and my predecessor before me was asking for another 5 years, so it's been 10 years. But finally, there seems to be some light at the end of the tunnel. They have put it in their budget finally. We have what we call a CAPEX budget. So it's finally in that budget, and it's supposed to be coming in by about February, March. So let's hope for the best. Yes, we have no training program, but I think we are slowly developing enough adequate personnel to start one. The other major private hospital will be Nairobi Hospital. They don't have any full-time gastroenterologists, they're all part-time, but they have all these services, including EUS. And actually, EUS is the only one available in this region. So the challenges are the same: financial constraints, purchases, maintenance, then lack of awareness of the service from a lot of the general population, lack of trained personnel, including doctors themselves and nursing staff. Because a lot of the training, it has been pretty much substandard. There are very few actually certified out of all the gastroenterologists that we have. Then lack of availability of training programs, which I'm beginning to gather is probably a very broad problem, which I think we should put all our minds together and maybe see what you can come up with. Then inadequate, well, maybe that was not the right word, but incentive, that's what I meant to say. We find a lot of my fellow gastros will not work in one region. So it becomes a bit difficult when you find somebody working in 4 or 5 areas. I think this is probably a ubiquitous problem. But I think to develop a proper program, people need to be very committed to where they work without having to work elsewhere, so that we help develop the unit. Then we've mentioned this mushroom of the YouTube endoscopies, which I think is going to put our endoscopy service into peril. So solution, obviously, we'll try to create public awareness, not just endoscopy, actually for the whole of gastroenterology. Then holding international conferences here at home, like the 2 conferences that we've had, has actually been a huge success. We keep on getting a lot of communication from delegates from out of the country who keep asking, like, for example, are we going to do a webinar this time instead of a conference because of this COVID? So it looks like it created something. There's an awareness that has just been created all over Africa. Then policymakers, this is now the dicey issue. We don't really have people who have our back, basically, to help push this. And we don't have any of us who is, for example, in the political scene. It would be nice if one of our senior gastroenterologists got into politics. I think that's the only way these things will start running, and we'll get all these resources even in the periphery. Then increase local training and certification, what we've just alluded to. Then increase these workshops like what we've been doing, even though I don't think it's adequate to do a 3-day upper endoscopy workshop every 3 months, but I think it is better than nowhere. At least people have some basis and they've actually gotten exposure. And actually, when they go back to their practice, even though you train on YouTube, you know something a little bit better. There's something about being trained physically than being trained by watching something and experimenting on a patient who basically could not afford to go somewhere where they could get better service. Then these webinars, I think like what we're doing now, has been a COVID-induced success according to me. In fact, I've presented very many gastro presentations over the last almost every 2 weeks. So there's always a small group of people who want me to discuss dyspepsia or something of the sort. So you'll have maybe 30, 40 delegates and that sort of thing. So I think that is helping to create awareness. So it actually came by accident. So it's maybe one of the blessings we got from this very awkward year. Then empowerment of our society, that is also one of those issues that is actually political, and it's all about the policy making. All right, thank you. That's what I have.
Thanks very much, Alan. That was obviously a passionate talk. I'm not sure if Masolwa can unmute and whether he can share his slides with us. He was having a great deal of difficulty with his internet connection. So could you just let us know, Masolwa, if you can, either in the chat or by unmuting, whether you can talk to us or not? I don't quite understand. Yeah. Can you hear us, Masolwa? Can you speak?
Sandy, I don't think we can hear him.
Yes, no. I think we should. So what I would like to do is for as many of you as possible to show us your videos and to show us to switch on your videos and to unmute. I'm not sure if you've got any questions or queries for Alan and for Leo, or any experiences that you'd like to share with us. Obviously, on a personal basis, many of us in South Africa have been involved with training in some of the countries mentioned, and we might be there. Masolwa, can you talk to us? Masolwa? We can't, yeah. I think for just now, we should just take discussion, and possibly next time we can tune in to see in the next echo you could give us your talk. So I think for just now, it would be good to get some input from anyone who would like to comment on these, and maybe I can set the ball rolling a little bit by asking. You talked about the situation in your country and this private public divide, but how do you see yourself increasing public advocacy so that you can improve the situation for endoscopy and for gastroenterology in general? Who do you think you can influence in the political sphere, or does it have to be a gastroenterologist who turns into a pathologist, into a politician? Perhaps Leo, you can talk to that. you obviously got 1/5 of the gastroenterologists that they've got in Kenya. So your task is even bigger, it would seem. Perhaps you can unmute and just give us your thoughts on how you really take the public sector forward, or is that just too complex to address?
Thanks, Sandy. I think the last thing that you mentioned is probably the correct answer, which is that it is quite a complex issue. I think the other thing to remember as well is a lot of us are overwhelmed by clinical duties and research, and we tend to run away a fair bit from the administrative side of things. And because of the dichotomous nature of the health system that I mentioned, a lot of us also divide our time between the public and the private sectors. But I actually think that ultimately what's going to work is role modeling in terms of you to the younger trainees. And then as the public sector also sees what's actually happening, one hopes that they get attracted to improving the lot. So I see this as small little incremental steps rather than expecting a revolution. And one just hopes that you don't get burnt out in the process. Thanks.
Thanks. Alan, you obviously practice mainly in the private sector, but obviously you're worried about the health of the nation. But do you? One of the things that occurred to us for people wanting to try to set up some form of training is that perhaps they could spend half their time somewhere else and half their time in your environment, and that once you try and take on possible liaisons with universities, a bit like the WGO has done in terms of its training centres. But obviously not all the training centres in the WO are actually have a formal training program in GI. And perhaps universities can take that issue of training forward. I'm not sure how moneyed or politically in the know they are. Perhaps you could enlighten us on that aspect, whether you think a joint training program with either your gastroenterology society or with an institution would be beneficial with say another country here.
Yeah, I think that's actually what I was alluding to, that now that we have more people on the ground, definitely having a joint kind of training will be more beneficial, like what they're doing at KNH. I think it will be a bit easier now that for us, we can invest also, there's no public or private sector. We're just, it's called a non-profiting organization. I think it will be much easier for us to collaborate with maybe WGO or any of these other centers to actually create some sort of training program, and maybe with some sort of exchange program going on or something of the sort. I think it will be easier with what we already have on the ground.
Yes. I think also it's I don't know, Chris, have you got anything you'd like to add?
Yeah, Sandy, Leo and Alan, thanks very much. I just wondered whether you felt a governing sub-Saharan association might act in a different way to kind of propel things forward as we're putting more effort, and as you're putting effort nationally, and as each country in sub-Saharan Africa is putting in effort nationally, whether an association like GASA, the Gastroenterology and Hepatology Association of Sub-Saharan Africa, that has been announced but is not functioning yet, whether that kind of input might be required to give the extra boost. It would kind of unite all the activities under a governing association and might just give the extra propel that we need to take everything to another level. I just wondered if you could give me your views on that, Alan, and then maybe Leo.
Okay, I think I agree with you totally. We need to be I think it would work better if we're unified. I mean, we keep going for this other conference, the European conference, where they combine all these countries in Europe and even in the US, the DDW. We don't seem to have that here. Like now that we've started having these conferences, I know they have conferences in Ghana. I know we have the hugest one, obviously, South Africa. We've also started here in Kenya, but I feel it's very disjointed. I think we need to come up with something and just basically do things as a collaboration and as one. I think that will definitely make things easier. Like, I don't understand why we will have 2 international conferences with international speakers from all over the world being held within the same week, within the same sub-Saharan continent. But I feel like there's a lack of unity. So yes, I think unity is important for us going forward. And it will basically give us a louder voice in whichever forum that we decide to focus on, whether it's empowering our own individual gastro societies, policy making, in terms of training. I think as a single voice would probably shout a lot louder than each of us simply doing everything on their own accord.
I mean, that does make sense to me, because you hardly have critical mass in terms of gastroenterologists. But you know, it's hard to have critical mass when there's only 4 of you in the country, like Leo is. So again, it's sort of, how do you get just past that? Even getting up to 20, 25 or 30 gastroenterologists makes things probably a bit more viable in terms of that. So I think this sort of sharing of educational resources that this platform allows is a very good way to sort of, provided you integrate it educationally into the system. I think it has an opportunity. And obviously things must be relevant to your practice. I think that's the other real problem. The need is for basic skills training rather than advanced. And one of the things is that I found in some of the sub-Saharan Africa is you want to run before you can walk, and do advanced procedures when the infrastructure for that type of support isn't necessarily in place. So again, it's interesting to hear your views.
Leo?
Yeah, please. About the Gaza story.
I think, thanks, Chris. I think the short answer is yes, but at the same time, just realizing that we share so many similarities, but we also have differences, and one just needs to find that sweet spot where you can carry everyone together.
So having heard that, then, I mean, the will is there. I think obviously economies and money is obviously the issue that's holding it back. But I think if we get a critical mass or a small group of people that are really motivated, I mean, I could assist in taking it to the next level. So I'd really invite anyone who's interested in maybe propelling this or getting this going, to let us know, so that perhaps we could start, making this viable. Obviously, it's going to start very small. It has been announced. The will is there. The desire is there. We just have to take it to the next level. So perhaps you could let us know, and we could form a small quorum and discuss how we could take it to the next level with the foundation's assistance, obviously from a resource point of view, and also from a kind of guidance point of view.
I think with those words from Chris, I think we should call things a halt on this aspect of today's meeting. I'd really like to thank Leo and Alan, and I know also that Masolwa put in a lot of effort to try and get us together, to get his presentation together. So I'm sure we can interact with him going forward. And again, Chris is slightly younger than me, but I think one does need the younger gastroenterologists to take a leading role in trying to put things forward and take over from the old guys. We might be a bit set in our ways, and we need your impetus to actually get us over, get the process going forward. So thanks both of you for participating and for your insights. Next up is
thank you,
Colin. Thank you, guys.
Thank you.
So Colin and Dion Levine, who's sitting in the background somewhere, have been working on this project probably for the past 18 months or so. And it was stimulated by David Metz and then subsequently by Peter Marfentheimer regarding H. pylori. And of course, there is this story of the African Enigma. And so I'll let Colin tell the story of his research project, which is now at the write-up stage. They've recruited their patients and have some results to share with us. And again, it's to show you that you can conduct research. Leo is conducting research. Alan is conducting research. And that it's important that you can also use this forum to discuss your problems that you might have with research and how we could help take them forward. So Colin, if you could share your screen and just enlighten us, and we'll take it from there. Thanks very much.
Perfect, thanks. Thanks, Prof. I hope everyone can hear me. I think I've unmuted and I think my video is on. Chris, just give me a thumbs up if you can hear me, please. Perfect, thank you. So yeah, thank you very much, Prof. My name's Colin Rush. I'm a gastroenterologist that has moved across from the public sector into the private sector in Cape Town, South Africa. And I'm going to be presenting a little bit of data that we have put together on Helicobacter pylori characterization. I think the importance of a presentation like this on a platform like this is to sort of indirectly provide answers to some of the questions that we have already posed on this forum about setting up infrastructure. And sometimes research actually has very positive impetus at sort of setting up sort of endoscopy units, especially if we've got other collaborative services in the rest of sub-Saharan Africa. And maybe that's a nice indirect way for our colleagues in Tanzania and Zimbabwe and Kenya to maybe drive a buildup of infrastructure, to commit to collaborations on research of sort of low-hanging fruit, which really H. pylori can be. Having said that, let's just get going with our presentation. So we know this from H. pylori and the fact that it is a type 1 carcinogen. Being a carcinogen, it obviously drives gastric cancer through a very well-defined sort of gastric carcinoma sequence. And the important thing is that if you understand that that sequence occurs, then there's obviously a process in which you can identify it and you can potentially treat it and hopefully prevent a cancer from forming. But the important questions that you have to ask is that not everyone with H. pylori gets a gastric carcinoma. This is probably demonstrated even more so in sort of a fable that has been termed the African Enigma. I'm not so sure if I completely agree with this fable, but I think it's important that it does get represented and it does get discussed. The African Enigma stems from the fact that H. pylori in sub-Saharan Africa is probably ubiquitous in the sense that it's almost got a prevalence of up to 60–70% in our general population. What we do know is that the pattern of this infection, the age of the acquisition, and the environmental, dietary, and genetic influences that the bug as well as the host is exposed to are very, very different from the West. What I don't include in this presentation, but what is an important topic, is the fact that there is different ancestry of Helicobacter pylori, and this has been demonstrated from a European ancestry, an African ancestry, and America-Indian type of ancestry. And when you start dealing with different ancestry, you're dealing with different genetics. And when you start dealing with different bug genetics, you have different various factors. The important thing is that the pathogenic role and clinical relevance should therefore be viewed differently on different continents and depending what sort of ancestral strain you're dealing with. The African Enigma is kind of based on the fact that gastric cancer rates are directly related to H. pylori infection. And in a place such as Africa, or on a continent such as Africa, where we have such high prevalence of H. pylori, we aren't necessarily seeing the such high incidence that you would expect of gastric carcinoma. One could potentially say that this is necessary. This is actually more of a result of underreporting because of a lack of data that's coming from countries of sub-Saharan Africa. And one of the arguments is also that our life expectancy is maybe a little bit shorter than other first world countries. So patients don't necessarily progress to cancer, gastric cancer, before actually passing away from other causes, HIV, TB, other infectious diseases. And the important thing is that this needs to be acknowledged. What we do know, though, is that although there is a possible African enigma, we do blanket ourselves under certain European-based guidelines, such as Maastricht guidelines, on how to diagnose, how to treat, what our outcomes and epidemiological outcomes are for H. pylori. And maybe it's important that we start thinking about developing our own type of African guidelines specific to our own ancestry in terms of H. pylori, as well as the hosts. And I think that's really the relevance of this presentation. The important thing is that, that when you're talking about this gastric carcinoma sequence, you have to understand that there's two big role players. And the two big role players are what we understand on the left, being that of the bug. The bug is Helicobacter pylori, and you do get different types of bugs, and we are going to refer to one as being a bad bug. And then, of course, you need a susceptible host. That's the person that is obviously infected by the H. pylori. And the importance is that it is an inflammatory sequence that generates pre-malignant conditions and ultimately cancer. So therefore, the genomics of the host that drive the susceptibility to progression to gastric cancer. And it's important to acknowledge that bugs and hosts therefore differ. And this is probably what the characterization should be based on. So we embarked on a study that looked at, in our Western Cape, which is one of the provinces in South Africa, a Helicobacter pylori characterization study. Myself and Dr. Levine with Prof. Sachedi, Prof. Thompson, and Dr. de Villiers, part of AMPATH, who assisted us on the science side of things. And really what we wanted to do is that we wanted to begin the process of characterizing Helicobacter pylori in the Western Cape. And we really wanted to devise the premise, and we really wanted to sort of formulate the process in which we could make sure that we could ultimately get the necessary data points from our specific methodology and test the proof of concept. And I think that's what we've done. What we've done is that we've looked at characterizing H. pylori in terms of probably one of the more important things, sensitivity. We focus specifically on clarithromycin, the backbone of its therapy, the genomic sensitivity. This has also been looked at in different parts of South Africa. And I know Prof. Cassinides and Prof. Reid Ali have helped us with regards to this up in Gauteng. Then we've also focused on bad bug in terms of the bug virulence factors, and the two common ones, Kage and VAC-A, and the mosaics that come with it. And then we've also looked at specific host inflammatory polymorphisms that might drive inflammation to ultimately progress to gastric cancer or gastric carcinoma. This is just a basic methodology of what we put together. I know it's quite a detailed slide. Ultimately, at the end of the day, we took patients that presented to our clinic that were dyspeptic and fulfilled criteria thereof. We ultimately allowed them to undergo an endoscopy upon their consent. And within that endoscopy, we did a gastric mapping of the stomach in keeping with the Sydney criteria. From those biopsies, we could do a RUT test or an HB fast test to determine whether they are Helicobacter pylori positive. And if they were, we divided the subsequent specimens, and we sent some more for histological testing, and we sent some more for our analysis with regards to our study. And from that, any specimen that we had gastric tissue, which ultimately provided us genomic data, genomic material for the H. pylori, for the bug. And it also, under consent from the patient, provided us with genomic material for the human host. And that really allowed us to look for the two data points as we've specifically spoken about, as well as the sensitivities. So when we refer to bad bug, just a short synopsis of this, okay, we were looking at specific virulence factors. The first one was VAC-A. VAC-A encodes a vacuolating system or vacuolating cytotoxin. The two main polymorphic regions for this are designated S and M, S being an active vacuolating activity, and M being more effective binding of the bug to the human cells. And ultimately, when you get mosaic strains of these, you get different types of virulence as demonstrated by VAC-A positivity. VAC-A, S1, and M1 mosaic strain has been documented to be consistently more virulent out of the rest of the type of VAC-A positivity. And these strains have been linked directly for an increased risk of peptic ulcer disease, atrophic gastritis, and ultimately carcinoma of the stomach. And it probably increases your risk 5 to 6-fold. Then we're looking at Kage Effectors. And Kage Effectors, looking specifically at strains representing Kage gene. Kage is a protein that is translocated by a secretion system into gastric epithelial cells and ultimately induces inflammatory interleukins and induces inflammation. And remember that inflammation is the driver of that carcinoma sequence to eventually become a cancer. And we know that Kage strains have been linked with an increased risk of, again, peptic ulcer disease, the premalignant gastritides that we sometimes see on histology and scoping patients, as well as the carcinoma of the stomach. Then we also look at host inflammatory risks, and the host inflammatory risks are those hosts that are susceptible. Now, this gets a little bit complex, but ultimately at the end of the day, inflammation is a balance between pro-inflammatory cytokines and anti-inflammatory cytokines. The pro-inflammatory cytokine of an interleukin-1 beta 511, that is what drives inflammation. And we know that there's certain SNPs that carry certain alleles and lineages that confer to an increase in inflammation. And then there's an anti-inflammatory cytokine called an IL-1RN or IRN, which counterbalances potential injury. And we do understand that if there's a variant, if there's a certain number of tandem repeats linked to this cytokine, it confirms underactivity and it allows for inflammation to be driven. So that's specifically what we looked at in the cells of the human host on the biopsy specimens, looking at an imbalance between the two. And ultimately, when you do have a pro-inflammatory state, this obviously has been documented to increase your risk for gastric carcinogenesis. So just some of the interim results, and this is unpublished data, but really we had about 89 dyspeptic patients that were enrolled in our study. 48 were H. pylori PCR positive, and this confirmed in sort of an incidence of a prevalence of about 54.9% of H. pylori, which really is in keeping with the data that we know. Quite interestingly, 100% of our specimens were genomically clarithromycin sensitive. And that is just a very interesting data set point in terms of how we treat it, as we know that sort of we need to make sure that clarithromycin sensitivity is at least up to 85% when we're using this as a backbone in terms of our treatment. Now, the results in terms of the bad bug and the virulence factors, 33% of our patients did not demonstrate any Kage or VAC-A pathogenicity. So 33% of the bugs didn't have this. 32 out of the 48, which is about 67%, were positive for VAC-A. And then specifically that higher virulence mosaic that I mentioned in the beginning, M1 and S1, was demonstrated probably in about 63% of patients. What is important is that 20 out of the 37 patients were both VAC-A and Kage positive. It was also quite an interesting finding to note that no patients were Kage positive and VAC-A negative. So VAC-A could be used, so Kage could be used as a surrogate marker for both VAC-A and Kage positivity. And out of the patients, out of the hosts and the bug that had the worst or the highest risk of virulence, Kage positive, as well as VAC-A, M1, S1 mosaic positive, about 42% of patients were infected with the bug that had this type of strain. When you're looking at the interleukins, interleukin-1 beta 511 was sequenced in all of our 48 patients. The highest risk allele of this was that demonstrated TT or TC alleles, and this was represented in about 85% of our population that we sampled. We were able to get some data on IL-1RN, variant number of tandem repeats, which, as I mentioned earlier, confers to a reduction in anti-inflammatory processes within the patient. The problem is that we only got 25 biopsies that were representative of this, and only 8% actually demonstrated the high-risk allele for an inactivity of this inflammatory marker. So if you had to have a look at what the worst bug was in terms of Kage, VAC-A, mosaic, M1, S1, plus a bad host that has ultimately ultimately a high pro-inflammatory state, then we would note that about 42 or 20 out of 42 of our patients actually demonstrated a bad bug and a bad host, which confers a high risk for ultimately progressing to gastric cancer. So this leaves us with the discussion points. We have demonstrated that about 50% of H. pylori infected patients undergoing endoscopy for dyspepsia will have a potentially virulent strain of H. pylori. The highest risk, 42%, demonstrates the Kage VAC-A mosaics as discussed, in combination with a interleukin profile that generates inflammation. All Kage positive specimens were VAC-A M1S1 positive, so this could potentially be used as a cheaper surrogate marker for this virulence factor. 100% genomic clarithromycin sensitivity in the population study. This obviously needs to be tested against the controls and specimens. And again, noting that this was only genomic sensitivity. And I think one of the most important things, especially when talking about collaboration, is that this data was all possible from simple biopsies. We didn't need brushes, we didn't need stool samples, we didn't need much else. We just followed Sydney protocol, 5 biopsies of the stomach, and we were able to get quite significant data, both in terms of virulence factors of the bug, as well as in terms of inflammatory genetics of the human host. This then adds to this slide, which was seen in Sage's presentation in the last week. Obviously, we all know the Maastricht guidelines, which is something that really dictates how we manage H. pylori and diagnose and manage it. But ultimately, at the end of the day, we don't know what strain of H. pylori we're dealing with in our country. We know that there's obviously virulent bug and susceptible host. And what we should be doing is that we should be collaborating in the right format so that we can ultimately characterize sub-Saharan African H. pylori, so that ultimately we can dictate to our patients sub-Saharan Africa how to diagnose it, how to treat it, and how to follow these. And with that, I think I'll come to the end of the presentation and I'll hand back over to Prof. Thompson for any questions. Thank you.
Thank you very much, Colin. I really appreciate that. I'm happy to take any comments. I don't know if anybody's posted anything in the chat room at all.
Rusheka, I wonder if you had any comments to make?
Thank you, Chris. My comments are directed firstly to Leo and Ellen. As they said, they both trained here. And I think it's really been wonderful to see how well they're doing and what they're doing for gastroenterology in general, for the subspecialty, but also advocacy for the patients that they see. And all I can say is I want to encourage their efforts, and they must please reach out to us if there's anything else we could do to facilitate these processes. As Ellen says, COVID has given us some gifts, and it's wonderful to be able to see both of them online, because clearly their face-to-face meetings were not possible even pre-COVID. So I just want to encourage them on the work that they're doing. And as Prof. T said, some of the challenges that they raised, we face here too. We are in a better position, but I mean, I think these challenges are faced by all of us in resource-poor settings. And then my second comment I'm directing to Colin. And again, I want to congratulate Colin. During his training, he, supervised by Dion Levine, started this project. And it wasn't easy to get it off the ground, what with all the challenges that we all face, which is the clinical load, funding, and other issues. The first round of trying to recruit patients and trying to characterize H. pylori and culture it was fraught with problems with the transport media and so forth, and getting a lab and a biochemist and so forth to actually do the work. But they persisted, and now they've come up with what I think is really fantastic data. I mean, as we all know, we have limited, very little data. In fact, if you do a PubMed search on H. pylori research in sub-Saharan Africa, there are places, Ghana, Kenya, Ethiopia, that are publishing on this, but really very little data from South Africa. So I think this is a really nice study that shows, what can be done, and as Colin says, that with your routine management of patients, that you can really get a lot of data. And I think this is a perfect platform to really work towards this sub-Saharan guideline akin to the Maastricht. And I'm busy now collating the authors that we will invite to the working group to start discussing these issues. And as Prof. Cassinides has said before, that we will then request Professor Mafaltaina to guide us as to how we break up into working groups into the different subsections of H. pylori. Clearly a lot needs to be understood. And as Colin says, there's lots that can be achieved within our own grounds, within our own hospitals, within our own practice, daily practice, and we can get data that we can start to begin to unravel the enigma if you believe in it. And as Colin says, even if you don't believe with it, data will speak louder than any other opinions that we might have. So those are the comments that I would have. Thank you.
Can I just interject here? I was on a meeting yesterday with the WGO Research Committee, and they're putting forward a protocol. Again, Colin alluded to the fact that this is just a biopsy specimen. But one of the other problems is obviously you need the logistics of trying to process these samples. And cross-border transfer is, within your own country, it's difficult enough. But cross-border is even more tricky with transport of specimens. So the WGO are looking to try and get a collaborative study looking at clarithromycin resistance, but they're using pathology specimens, i.e. the biopsy specimens. They just need one sliver of it, and they will be able to do that. And apparently those types of specimens are easier to process and to get permission to transfer because they're obviously dead and they're not alive. But I think in our environment in South Africa, unless an individual drives the process, and I think we've heard that from Leo and Alan, and from Masola too, unless individuals are driving the process, we won't get much further. And I take my hat off to the youngsters who are doing this, Colin included, and Leo. To do a PhD, being one of only 4 gastroenterologists in Zimbabwe is an amazing feat, and to accomplish that with a training in gastroenterology at the same time is really quite special. And it's good to see that Alan is also making academic headway within Aga Khan. So we're very, very proud of that, and there are others who are trained in South Africa, Wisdom as well, who's in Zimbabwe, and from Ghana, that we really hope will take up the cudgel. So I'm not sure if there are any further comments from the rest of the audience. I'm happy to take any further comments. And I see we will endeavour to have a look in the chat box, because there's lots being written there, especially regarding activity and ideas about helping develop gastroenterology.
Can I just say, we've put quite a lot of effort into getting our methodology and our protocol in place, and it's quite difficult with ethics and council. So please, if there is anyone that wants to collaborate, then we're very happy to share this. So you don't have to sort of reinvent the wheel of trying to get the protocol and stuff done. So they're very welcome to get hold of us, and we'll very happily hand over our protocol for other sort of educational centers. Even in South Africa is a good start, just to try and get the ball rolling, and we can get someone in Natal, someone in the Eastern Cape potentially, and then eventually we can at least characterize H. pylori in the way that we've done it, and at least get South Africa done, which I think is quite easy to do.
Colin, could I ask, the clarithromycin sensitivity in other centers in South Africa were very different and may have been driven by phenotypic expression of the pylori. So how do you account for that? Do you think it's just different population groups?
Yeah, absolutely. I think in your work that you did, there was a big difference between the public and the private sector, and obviously your exposure. You just need 1 point mutation to blow your clarithromycin line. So that obviously accounts for the public-private sector. We don't have much private data in Cape Town and the Western Cape that I know of, and that's something that needs to be looked at. But to be honest, anything that is 100% in research has to be taken with a pinch of salt. And although this wasn't a primary point in our study, it would be something that we would have to go back and just do correct controls of. And again, this is just genomic expression. So it's just identifying the gene that confers potential, one of the genes that confers potential to carry resistance. This isn't actually, as you say, a phenotypic resistance that has been proven. And I think to have accurate data, you would need to have both data points.
And congratulations on excellent work. I just wondered if Dion had any comments to make.
Can I make a comment?
Dion Levine.
Can you hear me?
Yes.
Yes, we can.
I just want to say, actually, I don't think I want to say anything more about the H. pylori because Colin and, it's been discussed, but I just want to say hi to Alan. It's good to see you again. And I see you making great progress. And hi to Leo, who I've seen more recently. And thanks, Colin. That was a really nice way of actually putting something that's quite complex intuitively, and it makes a lot of sense. We just need to get this out now into publication, and that's what we're working on. But it was well
Good to hear, Levin. I haven't had you in like, I think at least 5 years.
Yeah, you must have missed me.
I won't pay them any compliments, but you're listening to the two best colonoscopists in the country. I think without impunity. They're bloody good at it. Anyway, apart from paying compliments to everyone else, I really would like to sort of wind things up. I really think today has been informative for all of us, and I think also very relevant to how this platform can take things forward and to practice in sub-Saharan Africa. I think we've also got an action agenda from Chris and from all the youngsters who are participating. Once you become fully fledged gastroenterologists, you owe your specialty to take it forward. So please keep doing that. We go into recess now, and so we will, at the end, wish you all the best for the festive season, however you celebrate it. And I would like to again thank Echo India. So this process of Echo started in New Mexico. Echo India are our support network, and they do a fantastic job of keeping us on the straight and narrow and trying to help us with the technical issues. As you know, in Africa, there are numerous technical issues, especially if you're trying to transmit. So my thanks to them, and to the backroom girls, Karen and Cheryl, who just get on with the job and badger you all the time. Please respond to them, and they are our guideline going forward. So to all of you, without further ado, I think we can close the meeting. And thanks to all the participants, senior and junior, and keep the ball rolling. And season's greetings.